Thanks for joining us. I'm your host, Raquel Faria. I am a doctor in internal medicine at the Centro Hospitalar Universitário de Santo António in Porto. Today I will be discussing challenging lupus cases with Professor Ricard Cervera and Zaira Moura from the Lupus Academy Steering Committee. Ricard and Zair, welcome and thank you so much for joining us today. So we're going to start with the case. It's a Zaire case, and it's actually a representation, so it's challenging always. So this girl, she was 16 years old, African descendant female, was diagnosed with SLE, systemic lupus erythematosus, 4 years earlier, when she was 16, exactly. Based on the arthritis, proteinuria, positive high titer anti-nuclear antibodies, dsDNA antibodies, SSA antibodies, and anti-Smith antibodies. All of them were positive. She did a renal biopsy that showed class 1 lupus nephritis. So the patient was treated with low-dose steroids and hydroxychloroquine. 1 year later, when she was 17, she had a pulmonary embolism and received warfarin because of the presence of persistent lupus anticoagulant. Another 3 years later, when she was 20, while she was receiving hydroxychloroquine, 400 milligrams a day, she developed hand skin lesions gradually. And 2 months later, she was admitted to the hospital due to chest pain and worsening skin lesions. So at admission, the patient was complaining of chest pain. She went to the emergency department. Her temperature was normal, blood pressure 130 per 70. The pulse rate was 90 beats per minute, respiration rate 18 breaths per minute, and oxygen saturation 98%. So everything almost normal, while she was breathing ambient air. She had normal breath sounds on the lungs field. She did lab tests, and we're going to tell you now before discussing, that revealed mild anemia, 10.3, low lymphocyte count, 0.9, normal platelets. INR was 2.3, so inside the target. Creatinine was normal. She had also elevated troponin T, 248 nanograms per liter, low C3, 55, positive anti-dsDNA antibodies, 45 units, and a proteinuria subnephrotic range, 1.5 grams per 24 hours. She had a normal protein electrophoresis with a diffuse increase in immunoglobulin, and the tests for lupus anticoagulant anticardiolipin antibodies were positive. The first EKG showed T-wave inversions in precordial V2. So, long presentation of a case. Zair, at this point, young SLE patient with chest pain. What do you think are the main differential diagnoses to the cause of this chest pain?
So I think that the clinical elements, the chest pain, the abnormalities on the EKG, and biological elements, elevation of troponin, are suggestive of cardiac damage in the context of active lupus. So if we focus on the causes linked to active lupus, there are 3 main diagnoses to consider. The first one is lupus pericarditis. The second one is lupus myocarditis. And the last one is myocardial ischemia due to antiphospholipid antibodies.
Okay, perfect. Ricard, do you have any aspect to add to at this point with this patient?
Well, I fully agree with Zair that this is the main differential diagnosis in these patients. I would like just probably to stress the importance to rule out a myocardial infarction in this patient. The fact that the patient has antiphospholipid antibodies with previous history of a thrombotic event, of a pulmonary embolism. This, although the patient was under correct INR, this should prompt always to rule out the presence of another thrombosis, in this case in the coronaries of the patient. So I think that one of the possibilities that we have to emphasize in these patients with lupus is the possibility of ischemic cardiomyopathy, of acute myocardial infarction.
Thank you, Zaire. It was your third etiology. You are worried about the activity of the patient and also if she's having any ischemic heart event. But this patient had proteinuria also, and it was not a low proteinuria, it was 1.5 grams a day. She had positive antiphospholipid antibodies. She had a previous thromboembolic event on her lungs, and she's on warfarin. Do you think that in this context, you would skip the kidney biopsy?
That's a very good question. And my answer is no. But in my hospital, we do kidney biopsies by transjugular way.
Yes.
So this kind of process allows anticoagulation to be withheld for a very short time, 12 hours before the kidney biopsy and 12 hours after. But I completely agree that in most cases, the kidney biopsy would not have been done.
So I think this would be a clinical, practical discussion in between specialties. What probably also it depends what we are going to find in the heart, but we tend to think, is it going to change anything? But actually, this is a young patient. They tend to surprise us. And Ricard, I'm absolutely sure you had these kind of discussions so many times in your clinical practice throughout the years. Can you share with us any protocol that you do have to do kidney biopsies in antiphospholipid antibody patients who are on anticoagulation?
Yeah, for sure. This is really a controversial issue, but I fully agree that it is very important to know what is happening inside the kidney, because in addition to inflammation, to lupus nephritis, the patient can have an antiphospholipid nephropathy that will require a very different approach. So I think that it is very important to perform a kidney biopsy in this patient. One option, as Zaire already mentioned, is transjugular biopsy. Another option is to perform a percutaneous biopsy, but minimizing the time that the patient is off anticoagulation, because this is a very risky situation in a patient with antiphospholipid syndrome that can develop even a catastrophic antiphospholipid syndrome. We have experienced patients who develop catastrophic antiphospholipid syndrome just after withdrawing anticoagulation because of a kidney biopsy and performing the kidney biopsy. So it's a very stressful situation. What our policy is just to switch to make a bridge of anticoagulation with low molecular weight heparin 2-3 days before the procedure, to stop the dose of low molecular weight heparin in between 12 and 24 hours before the kidney biopsy, and then after the kidney biopsy, just 12 hours after the kidney biopsy, again to start with the low molecular weight heparin, and then to bridge again to oral anticoagulants, to antivitamin K anticoagulants. So it's very important to reduce at the maximum the time that the patient is without anticoagulants.
Thank you. Actually, I have a doubt on something that it's really controversial. For instance, we do discuss it with some of the nephrologists. In your experience, doing the transjugular biopsy to the kidney, since it is going to take some part more medullary than cortical, have you found any differences on the result and how the histology should be interpreted during the percutaneous versus the transjugular biopsy? What's your experience on this?
Yes, this is a good question, but in our experience, and we have now more than 300 transjugular biopsies that we have published.
Very good.
Nephrology, dialysis, and transplantation, we have found that the kidney biopsies were very good, and the number of glomeruli was higher than 10 in most cases. So we use it routinely now, and this is very interesting for patients who are under full anticoagulation because the risk of bleeding is very low in this case.
Perfect, perfect. Thank you so much. Going back to the case, test result came, and this patient had low C-reactive protein, high troponin, we've seen the high troponin. She did a chest CT scan, which excluded recent pulmonary embolism, so we are ruling out that this was the cause, although clinically it didn't actually look like. The echocardiography, this, yes, was altered. Diffuse decrease in left ventricular ejection fraction, 40% of function, without left ventricular hypertrophy, and no dilation of atria or ventricle. There was no thickening of the mitral or aortic valves and no diastolic dysfunction. There were no pericardial abnormalities. So this echocardiogram is not okay. And she did a kidney biopsy. We don't know which the protocol was used, and it showed a class 3 with 50% of activity and 5% of chronicity. Zaire, now that these results came, what do you think it's really the most probable cause of this heart involvement?
So there is no pericardial damage on the echocardiography, which is very interesting because we can exclude in part pericarditis. What we did is first we did a coronarography to completely exclude myocardial ischemia due to antiphospholipid antibodies. And last but not least, the gold standard in this situation, we did a cardiac MRI, which is very useful to make the diagnosis of lupus myocarditis, and also to completely and definitely exclude pericarditis, because sometimes in lupus you can have pericarditis with normal echocardiography.
So you do find it's a lupus myocarditis. This is quite rare. And how would you treat her?
So finally, the diagnosis of cardiac MRI was done. Because SLE was active, the diagnosis, and because the diagnosis was lupus myocarditis, and also because she had lupus nephritis, class 3, we have decided to treat her with high dose of corticosteroids plus immunosuppressive drugs, mainly IV cyclophosphamide in this case. But I would like to underline that for lupus myocarditis, you can treat your patient just with high dose steroids. And sometimes you can have a good improvement without immunosuppressive drug. But because the patient had lupus nephritis, and this is why we did the kidney biopsy, we add IV cyclophosphamide. So
it would change. In your experience, the reference and the cases that have been reported show that African descendant is a pretty high risk for having lupus myocarditis, has been active, as you mentioned. In your experience, why do you think this can happen? What are the risks and the mechanism that could be here in this? Because I don't think lupus myocarditis would be on everyone's reasoning or for a hypothesis in these patients. So can you just please elaborate a little bit about it a little bit more?
So the patient with lupus can have viral myocarditis. So you have to rule out virus infection first. It's quite difficult for that, but lupus myocarditis, as you said, is very rare. It's more frequent in patients from Afro-American descent. It occurs during active lupus, global activity of lupus, and I think that's all. We don't have a good knowledge on the parameters leading to lupus myocarditis.
Ricard, do you have any additional comments?
Just a question to Sair. What was the dose of intravenous cyclophosphamide that you use? You use the Eurolupus regime or the NIH regime for this black patient having, in addition to lupus nephritis, having myocarditis?
That's a very good question. You know that this situation is very rare in lupus, so we don't have any evidence-based data for that. Yes. So what we did, because lupus myocarditis is severe, we often use the NIH regimen for this, but in some patients we are now using MMF directly or the Eurolupus regimen, but we don't have any evidence for that.
Thank you very much. I think it's a good decision. I think so.
You agree?
Yes.
Thank you so much. Thank you so much for discussing this rare case, and I hope that our listeners had a little bit more of a hint when a patient comes to them and thinking about lupus myocarditis. And let's move to the second case. So a 13-year-old girl, teenager, was diagnosed with systemic lupus erythematosus based on photosensitivity, arthritis, pericarditis, leukopenia, lymphopenia, and positive antinuclear antibodies, anti-dsTNA antibodies, and anti-cardiolipin antibodies. She was treated with hydroxychloroquine, 200 milligrams a day, low-dose aspirin, 100 milligrams a day, and low to moderate doses of prednisolone and methotrexate, 15 milligrams a week. 1 year later, when she was 14, lupus nephritis was diagnosed, and the kidney biopsy disclosed a class 4. Methotrexate was discontinued, and lupus nephritis induction of response therapy was started with prednisolone and low-dose pulse cyclophosphamide, the Eurolupus regimen, followed by maintenance therapy with MMF, mycophenolate mofetil, 2 grams a day. She achieved complete renal response, and MMF was withdrawn after 3 years of treatment as the current recommendations. Ricard, how would you decide the induction regimen today in young SLE women? Would you decide, what are the factors that makes you decide Eurolupus regimen versus MMF?
Well, for the majority of the patients, probably it's similar. Some studies that have compared both therapies have compared similarity between Eurolupus regime and MMF for the induction therapy. But there are some particular situations that probably will prompt us to use one or the other. And one of the situations is the potential non-adherence to treatment in adolescents, in young patients, like this was the case. In these cases, we prefer to bring the patient to the day hospital and to be sure that she receives the intravenous infusion, and not just to give tablets to take at home. This is a policy that we follow in many of our young patients diagnosed with lupus nephritis.
Zaire, do you have a different strategy? What do you think about all that can be said on cyclophosphamide in teenager?
I fully agree with Ricard, but in lupus, I think that the choice of immunosuppressant depends on the three main parameters. The first one is the patient's history. If a patient relapses under MMF, cyclophosphamide will be preferred, and vice versa. This is the first parameter. The second one is the age of the patient. The older the patient, the more MMF is preferred because of the ovarian toxicity of cyclophosphamide. And finally, and I think this is the main parameter, as Ricard said, the compliance. When the patient is not compliant, intravenous medications are preferred.
Thank you so much. And actually, she probably complied with MMF at the time, because she had 3 years of treatment and remained in complete remission. And she is now 17 years old. She was advised to continue hydroxychloroquine and low-dose aspirin, but you mentioned teenagers with chronic medical conditions and dealing with psychological problems. One of the main issues, as you mentioned, is adherence to treatment. And it was poor at this time, 17 years old. Poor adherence to treatment was suspected, as well as non-compliance with photoprotection measures. Over the following years, she presented several skin, joints, and pericarditis flare. They were treated with NSAIDs and low to moderate doses of prednisolone. And when she was 26, so 9 years after stopping MMF, she had a new flare of lupus nephritis with nephrotic range proteinuria, 4.3 grams per 24 hours. And the second kidney biopsy disclosed the class 4 with activity high and also chronicity. Hydroxychloroquine and aspirin were maintained, and enalapril 10 milligrams a day was added. And then you had to choose again for the induction response regimen, and it was done pulse methylprednisolone 500 milligrams a day per 3 days, with prednisolone 30 milligrams a day, and MMF was chosen 2.5 grams a day, following maintenance therapy with MMF also at a lower dose, 2 grams a day, and tapering doses of prednisolone. 12 months later of the induction regimen, she had a partial renal response, so a proteinuria of 0.8 grams in 24 hours. So at this point, she was 27 years old, and she said, I want to become pregnant. And struggling doctor, but she was referred to the preconception counseling clinic in order to advise regarding pregnancy and SLE. At this time, she has 14 years of duration of SLE. She has 1 year after lupus nephritis class 4 induction treatment, and she is on partial response. She has anti-cardiolipin antibodies positivity, no SSA or SSP positivity. Zaire, what would be your main worries with the pregnancy in this patient?
The first one is that lupus nephritis is not completely controlled, so there is a high risk of renal flare and worsening of the renal function during pregnancy, especially since most medications will have to be stopped during the pregnancy. The dose of corticosteroids is still too high, 30 milligrams per day, to allow pregnancy in good conditions. So I think that I would not have recommended to plan a pregnancy, but we should keep in mind that often patients are not following our recommendations.
And she's 27. So,
Yes.
and the attending physicians provided information regarding the need to wait, as you mentioned. It's not a good time until lupus nephritis was under control. And of course, the drugs, as you mentioned, for becoming pregnant, you should not be on potential teratogenic drugs. But guess what? 2 weeks later of the counseling clinic, positive test of pregnancy was detected. No one knows how it happened, but she was pregnant. Ricard, at this point, which of the following drugs should be stopped? And would you had any medications?
Well, this was a terrible news. And unfortunately, we had to advise that this was a very difficult situation that required, first of all, to change some drugs and to withdraw some drugs that were very important for her at that moment, but unfortunately are teratogenic and should be immediately switched. The first one was mycophenolate. Well, mycophenolate mofetil was switched to azathioprine. We switched to 100 milligrams a day of azathioprine. Enalapril also was withdrawn at that moment, and we really closely monitor the follow-up of that patient. We try also to decrease a little bit more steroids, prednisone. We stress that hydroxychloroquine and aspirin should be continued because these are drugs that are not only not teratogenic, but they are also beneficial in this situation. So with this new cocktail of drugs, she was released and asked to continue with our lupus pregnancy clinic.
And enalapril was also withdrawn. And actually the blood tests were, she had low ESR, low CRP, creatinine 0.9, proteinuria was 1.2 grams per 24 hours. She had normal complement and the pretty low positive dsDNA antibodies. She was so happy. During pregnancy, she presented several mild skin and joints flare that were managed with low to moderate doses of prednisolone. Her proteinuria remained stable between 1.2 and 1.8 grams for 24 hours, as well as all the other lab tests. And she managed to get to week 38, but she presented to the emergency room with severe headache and high blood pressure, 180 systolic and 100 diastolic. So she managed to get to 38 weeks. Ricard, which of the following conditions would you suspect with this severe headache and pretty high hypertension in this lupus patient that had several but mild flares during her pregnancy?
Well, certainly this was again another nightmare for our emergency room. The patient looked in pretty good condition and probably could be just a migraine and just a slight increase of the lupus nephritis flare. But the main problem that we should rule out in these circumstances is preeclampsia or the beginning of an eclampsia, that it's a very complex situation that will require very different management.
And some labs were asked, and she had a low ESR, a low CRP. Her creatinine, her function, kidney function, was exactly as it was on the baseline of the pregnancy, 0.9. But she had subnephrotic range proteinuria, 3.2. almost nephrotic range, proteinuria 3.2 grams per 24 hours, with a normal urine sediment. Uric acid was 7.8 milligrams per deciliter, twice increased liver enzymes, LDH 630, with a normal gamma GT and twice normal alkaline phosphatase and normal bilirubin. She had normal complement levels. So preeclampsia was diagnosed, and the administration of labetalol, 100 milligrams in 8 hours, was started. The delivery was induced, and a healthy female baby was delivered at these 38 weeks of gestation. During the puerperium, she developed no complications, and the proteinuria decreased to 0.8. So as she was after the lupus nephritis treatment. Zair, this patient, it could have been worse. She developed a preeclampsia, but at a full-term pregnancy, 38 weeks. With all this happening early in the pregnancy and having lupus activity as a differential diagnosis, would you have done something different? Would you consider lupus activity also here? What are the other worries for you at this time?
Yes, of course. I think that the increase of the proteinuria, because of the increase of proteinuria, we would have discussed a renal flare. And I think that we would have discussed a kidney biopsy. Kidney biopsy during pregnancy could be done until 3 to 4 months. And in this case, it could have been very important to make the differential diagnosis, to know exactly what is happening in the kidney and to propose the good treatment for that. And I think that in this case, we would have proposed a treatment with azathioprine or to combine with calcineurin inhibitors, which can be given during the pregnancy.
Yes, of course. Of course, we are discussing if this happened earlier in the pregnancy. At this time, the delivery would be the same. But would you be worried? So the thing is, coming back to the real case, delivery, healthy baby, she has 0.8 grams of proteinuria. How do you think the next few weeks are going to go? Would you be worried? What would be your plan for the next few weeks - 2-3 months?
You mean after the delivery?
After the delivery, yes.
I think that we would certainly return to the classical treatment with MMF, for example, or with IV cyclophosphamide. But azathioprine is also a good drug for the control of lupus flare. And again, we should certainly discuss a kidney biopsy to know exactly if the lupus is still active in the kidney, what is the degree of damage in lupus in the kidney, and to have the good treatment for the patient. So,
okay, thank you. Also, Ricard, even without flaring, and of course, lupus activity has also is always to be on the back of our mind, but she could have only a preeclampsia with all the risks that she had, and actually it went well. On this case, Ricard, do you have any additional comments?
Well, I think that what this case is teaching us is that in addition to all the scientific knowledge that we need regarding lupus nephritis, different therapies, and so on, we have to take into consideration the patient's personality. And compliance is one issue. Lack of compliance is a terrible problem. And also family planning and unexpected pregnancies. So this is something that we have always to take into consideration in the management of our patients.
Thank you so much. And we have been addressing treatment adherence and compliance in lupus patients through the podcasts. And actually, although this is a worry, in this case, is a huge worry for the physician who is taking care, we can empathize with the girl that has lupus since she was 13. Lupus is not okay, but she thinks it's better, and she is 27. So we can know what is coming from, but we really need to discuss this with them, because it was not really a good time to become pregnant. And these are things that we can learn from you, from the experts that have dealt with these several times, and try to reply to the patients and do the best we can. Thank you so much, you both, for these cases, challenging cases, one for its rarity, other for the challenging of some mismatch of concerns between the physician and the patients. Ricard and Zaid, thank you so much for joining me today and sharing these wonderful insights. To our listeners, we hope these discussions have helped you gain more of an understanding of lupus. Do send us feedback on cases you would like us to discuss in the future. Thank you so much for listening. We hope you enjoyed this podcast. Please leave us a review, which will really help us in reaching as many of your colleagues as possible around the world. Join us again next time.